thank you again for allowing us to show you this case. I think it's going to bring up some interesting discussion.
I'll just start. This is a 74-year-old woman who's got long-standing peripheral arterial disease. She's actually had mesenteric stenting before the Cleveland Clinic for about 10, 15 years ago. She's had a left iliac stent as well, long-standing tobacco abuse. Came to my clinic unable to really walk, legs give out, no rest pain, but she does have pretty fair claudication. Her quality of life is markedly decreased. Her ABIs are 0.49 on the right and 0.50 on the left. Next slide, please. So typical history, smoker, PAD, dyslipidemia. She's been married. She has one son. She's been smoking for a number of years, quit in 2016. She's actually having a reoccurrence of her mesenteric symptoms, which are generally diarrhea, but her main issues are that of claudication. She does have some re-narrowing within her stents that we're going to address later within the SMA stent and the celiac stent. But we're going to right now try to focus on the task at hand. Next slide, please. So a pretty thin lady. She's only 99 pounds, BMI of 17. She's had an abdominal worry, really no pulses on the right, some on the left, and all Doppler monophasic. Next slide, please. So we had a CTA, her creatinine's normal, but basically common iliac to the external iliac, complete occlusion, some recon of the CFA, quote unquote moderate disease on the left, common as well as left external iliac. Next slide, please. So we got a CTA for basically imaging, but also sizing. I think you can get an appreciation here that this is a very thin patient, and B, has some very, very small arteries. We use this basically for sizing, so we know exactly how big. You can see they're measuring around 6, at most 7 in their common iliac. So this is a different, not somebody you want to go up with your 8 or 9 iliac stents with. Next slide, please. So we did a diagnostic angiogram from the right iliac, right radial approach. You can see here her renal arteries are the only thing that looks good. The distal abdominal aorta has distal severe diffuse disease. We have no real beak from above, and essentially not much reconstitution in the right common femoral as was promised on the CTA. You can see on the left there's some disease in the left CFA as well as in the moderate disease in the external iliac as well as in the proximal common iliac. Next slide, please. Runoff on the left looks pretty good, actually. Mild disease all the way down, 2 vessel runoffs, they're not terrible. Next slide, please. Next slide. All right, so game plan was to make certain that we had, anytime you're going to do a iliac occlusion, our goal was to make sure that everything was prepped. We have 2 IVs. She's typed and screened. We have a coda balloon here in the room in case of an iliac rupture. We have covered stents in the room. We actually may probably just go ahead with covered stents. And then a very, very long informed consent with the family, discussions on options. Our quality of life is extremely poor. We went through why we're doing this, and everyone is in agreement that we should proceed. So safety first. Next slide. So initial game plan was the game access in the left CFA with a 6 French, which we have, was to go left radial with 5-6 slender, and then come on the right side low, potentially enter SFA. Attack from above, perhaps with a BB1 IM or a multi-purpose from the arm, and then below with a quick cross and live wire. Next slide, please. So game plan was crossing first, and we've been able to do that off camera with a reentry, and then proceed with IVUS, and then given the calcium that's there, probably go with shockwave, probably some covered stents, sizing, probably kissing stents depending upon where we entered, definitely now. Next slide. And so with that, I'm just going to turn back over to Prashant Kaul, my partner, and then recognize the rest of the team here, and then go through some of the diagnostic angiograms that we've done so far.
Yeah, thanks, Drew. So again, thanks to our team for helping us through this. Let's just go back 1 slide, please, if we can, Michael. And so, you know, there's a lot to discuss here, but before we do that, who's on the panel? Who, if we could just hear who we're talking to, that would be great. We can't see you, unfortunately.
Yeah, Prashant, this is Bo Hawkins. I'm one of the moderators.
Hey, Bo. Hey, Bo.
Good to see you. We have here Dr. Jay Gary, Eric Sasinski, Vikas Agarwal, and then Alyssa Alden.
Okay, fantastic. Well, it's nice to be doing this case amongst friends. So look, you know, the initial diagnostics were quite sort of, you know, scary looking, nasty. I think. They're very nasty. But, you know, the recon sort of more distally in the common femoral was really there wasn't really much there. So, initially our thoughts were to come from above and use the left radial, but really we had some issues with that too. So Drew, why don't you show where we are so far and what sort of roadblocks we've had up to this point? And then maybe amongst the panel, let's have a discussion about sort of strategies and what the next best option might be.
So initial access for me was under ultrasound access of the left radial. I actually was able to get a 5/6 slender sheath in. And then under ultrasound micropuncture, I was able to get into the left CFA as well. You can see there's a stent right there. Micropuncture, making sure it's spinning. It's a lot of disease in there. And then I had a little resistance with my J-wire, so I just did an angio. It looks beautiful here from the arm. And then as I went forward, I used a versicolor wire to be able to traverse. And I thought, great, we'll be able to come from above. And I kept hitting resistance. And lo and behold, surprise, 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 her left subclavian is occluded. So now I know two things: never to check her blood pressure in the left arm. It's going to be dramatically different from the right arm, so that's important. And additionally, well, she doesn't have a lemograph, but this is obviously something we need to take care of. So as such, we aborted our up plan, and I was able to get access under ultrasound here a little bit lower, intentionally down into the SFA, using a micropuncture technique and 4 French. And once I was able, and I was trying to get into, as you guys probably saw on the diagnostic, the lateral circumflex iliac, but I could not get that wire in the lateral circumflex iliac. So basically, using the dilator off a precision sheath, I was able to get a little bit of support, and with a little bit of time and some persistence, get my micropuncture wire up, and then I used my dilator essentially right there over the micropuncture to kind of push through the occlusion from below, using the calcium as a guidance, hoping that we weren't obviously outside the vessel wall at that point. We did come in from the other side. You can see that's a stiff angle glide wire with a now quick cross 0.03590. And so we're just traversing up,
So,
trying to get...
Drew, I'm going to stop you there for a second. So, guys, so you can see this is sort of how this case initially started, and we'll obviously show you what happened next and where we are now. But why don't we kind of pause for a second and get some thoughts from the panel and the group on, is this the strategy you might adopt? What would you have done differently? And what would be your next steps from here?
So you all did have the right radial for the diagnostic angiogram. Did you consider reaccessing that and then taking an R to P down that way for an additional retrograde type of shot at the striatum? I'm sure you considered it.
Yeah, no, I did actually. If you'll notice, I actually have the right radial prep. When I did it was with a 4 French sheath, and it was pretty tight. I was a little bit worried about
we went through that exact same discussion, but unfortunately, both by ultrasound and at the time of the previous attempt, the caliber of the radial artery would not have taken the 6 French sheath, and of course the R2P, the smallest is 6 French, so that we kind of discarded that option. So in fact, the left radial sheath is a 5/6 slender.
Yeah, my thoughts on looking at it is that I didn't see a clear antegrade stump. I think you're going to have a world of pain trying to cross this antegrade or get into the stump antegrade. So I probably would have done what you guys are doing and stick low on the right and see if you can get lucky coming retrograde up as you're doing. That would be my first approach.
Yeah, I mean, it's scary. I mean, Drew, you did a great job. I think that Eric Sasemsky, and I think sticking as, in that proximal SFA is always the right strategy here, and you can do that safely and close that. And so giving yourself, even if you can just get half your sheath in and then work with that in place, and then again, for the audience, the radial approach works great. Typically I'll take a 1/19 centimeter if I can get it in to the bifurcation and use that to cross, and that's been successful, but it's really tough for smaller. You said I think she was 99 pounds.
99 pounds. Yeah, very
spasm with a 6 French R2P sheath. Left radial, shorter distance than right, but I think this is what you had to do, right? I mean, you can try from up and above. That wasn't going to work probably. By the way, the aorta looked pretty diseased on the infrarenal aorta on the first DSA, but that last shot you showed us looked a little bit more normal caliber. I don't know if that was something you were going to address or if that was something you're going to leave.
We'll show you that too here in a second, but let me ask the group also. So when you're in this kind of situation, so you've obviously, it's a very long occlusion, so the likelihood of remaining through lumen is low. So in terms of your sort of subintimal work and dissection reentry strategy or otherwise, what would be your favorite approach here? Would you kind of re-enter with a re-entry device? I mean, the other option, of course, especially if we had antegrade access, would be a cart or reverse cart. So, any thoughts about that?
Yeah, I think, I think IVUS can be very useful here, even from your contralateral, can precisely show you where the bifurcation of the carina is going to be. And so you can use that to kind of landmark where you think you might need to re-enter. I think that's important to use. I would not do, and I think you're right, this is so calcified, I think you're going to get subintimal. I mean, maybe there's a few stellar operators, not me, that can get through this thing true lumen the whole way, but I think that's less likely. So I'd probably dissect like you're doing, get up to near where I want to re-enter. And I would probably use, ultrasound IVUS guided reentry here with the Pioneer system, just to make.
Yeah. So also, just in the interest of time now, why don't we keep going with what we've done so
Sure.
far, and then we'll keep moving here, just so we can actually make some.
Yeah, so I'll do
progress
this
for you on camera.
while Prashant's going through here. So basically, that's where we were, by the way. You can see we're in the SFA when I back that out, the change out for sheet. So we were clearly subintimal. At this point, we're trying to basically, we've moved up a IVUS guided reentry to try to be able to punch back in with the Pioneer, and you can see how diffuse that distal abdominal aorta is disease-wise. Getting this aligned was not very easy. I usually try to go multiple angles to kind of make certain that we are where we think we are, and you can see actually in this case we actually got a little bit subintimal with the needle. Going up a little bit, but being very cautious and being certain that you know exactly where you are is important. And so I think going above, you can see how much disease there really is throughout that distal abdominal aorta. It is quite heavily. There's the IMA right there. So under reentry, just trying to get to our reentry shot here. Make sure that we're passing. So that's needle going up. That's it right there.
I think the other important thing to be aware of here is those lumbar collaterals and the IMA. I think I believe both the internals are out. Certainly the one on the right is, but the left I think is out too. And so if you disrupt any of that, that can lead to problems for the patient down the road. So being careful about reentry here, not jeopardizing those, is exceptionally important.
The other thing is now the reentry is obviously in the distal aorta. It's about looks eyeball-wise 2 centimeters up from the bifurcation. How do you think, Bo, what does that mandate in terms of your strategy for the distal aorta? Do you have to reconstruct up higher? Are you going to recreate the carina with kissing stents all the way up? Are you going to drop a kind of a top cut stent in the distal aorta? You're going to do the CRAB technique. What's your option here now that you entered up higher?
Yeah, it's tough. I do feel like the aorta looks diseased enough, like it needs to be treated. Traditionally I've just run the bifurcation of the kissing stents a little bit higher, but I'm not sure that that's sufficient here. So CRAB might be something to consider. What do you guys think down there?
Yeah, I wanted to see that image again that we saw before, but again, off that DSA originally, it looked like CRAB was probably the right way to go.
I'll try to get that picture for you, Eric.
Yeah, I agree.
And then Drew and Prashant, just so you're aware, Kenny Rosenfield's now joined us too, so we need to get some input on.
We could use Ken's help. That's a hard case.
Nice, easy case. So that's what we're starting with here. It's kind of a nightmare.
So, we've got through, we have a Grand Slam wire up now, and what we've done is we've just taken a shockwave balloon here now next as our next strategy, because obviously there's a ton of calcium there. So that's our first treatment strategy here, which we're going to do with you here live.
Ready? Go ahead. Yep. So the idea here is I really want to be able to push all that. You could see down. I thought that was a stent initially. The first time I took those pictures. Go to 2, please.
There's 2.
Go ahead. The shotgun. Go ahead, Charles.
What balloon is this?
I'm sorry?
This is an IVL balloon. What is 6
IVL
millimeters?
balloon. It's an M5 plus.
6.0 size.
6.0. So you guys, I think the nice part is it's the fast. It's so much nicer using the M5 plus. It's 2 per second. And life is so much faster now when using that. And the other day I had to use 2 of them. I had to went from M5 plus down to 5 to the regular, and it was quite boring for the next 3 minutes.
And Drew, you're in the subintimal space here, is that correct?
We're true lumen proximally up in the aorta. Yep. And we're subintimal probably halfway down. And the idea I think our thought process here is if we can expand that subintimal space and crack some of that calcium that you see right there that's pretty intense, then we'll get better expansion without tearing the vessel.
And can you tell the crowd how high
What do you guys
pressure
think
going
about
on
using
this
shock
IVL balloon?
subminimal plane?
Yeah.
And Drew, how high pressure are you going on this IVL balloon? I mean,
Just
I
2
think what
atmospheres
Eric
right
was
now.
alluding to is fear about being in the
Lost audio.
subintimal space with the IVL.
Go ahead. Yeah, we're just at 2.
Not
Can
only,
you still
not
hear
only
us?
fear, but also just the necessity. You know what I mean? I think we underappreciate sometimes subminimal plaque and calcification. And so
Jake,
obviously
you
this
guys
is going to be
also
a
can hear us.
stenting approach. So you want to make sure you're ready to stent.
Ken, what do you
Michael, I'm
think
not sure
about
they
the
can
role
hear us.
of
Can they hear
IVL
us?
here versus just the traditional way of, ballooning your subintimal
seem
throughout
like
the
it.
common iliac here with heavy calcium and a tiny vessel? It's a horrible case.
Okay. You want me to go to 4? Or?
Yeah.
I don't know.
Yeah, there you
I
go.
don't think we have established that one way or the other. So I don't think it's a bad thing to do. I'm not sure that it's needed, but
Yes, go
Can
ahead.
we reboot a rehearing so those guys can hear us? Okay?
I mean, I
just
think
want-
the
Yep,
the
there you
reason
guys
for
are.
doing it,
Sorry
I
about
guess,
that, we're
is
having some connectivity
try to
issues.
reduce, in theory, reduce the chance of tearing and causing something that requires a coverage stent. And that's the reason in theory to do it, but I'm not sure that's necessary. I'm not sure.
The argument for IVL use, I think, would follow, as you're mentioning, that you may enable yourself to stay very low pressure with the actual balloon, but still maybe get the benefits of kind of focused high-pressure ultrasound on the plaque. That would be the argument. It's obviously a little bit of a theoretical argument. How does that sit with you, Bo?
Yeah, I mean, I think IVL makes a lot of sense, and I do believe that it theoretically probably lowers perforation risk. I can't show solid data that supports that, but I think this is probably what most people are doing in practice.
Yeah, just FYI, we do have 2 7-front sheets in. The idea here is we need covered, and we have covered BBXs here. I think the challenge here is obviously, covering up those big lumbar collaterals. That's going to be a little bit of an issue. Not something you necessarily want to do if you don't have to. So I'm just going to come down here and just treat this whole segment.
So let me pull the panelists really quickly. I think if I know Drew well enough, he's probably going to select covered stents here for a variety of reasons. But Dr. Alden, what's your default stent of choice when you're doing complex iliacs? Is it covered, bare metal? Depends. How do you decide?
Guys,
I'd side with Drew and pick a covered in this case.
Teresa, she's moving.
Okay, what about you, Dr. Agual?
Yeah, I would do the same. I personally,
Pressure's still good.
so what I would do is, or at least I used to try to be self-expanded in the external iliac, balloon expandable in the common iliac, just with the tortuosity. But for a CTO, stay covered stent, don't take any chances.
What do we think about the concept of, bilateral, potentially covered stents across the internal iliacs? What are you guys thinking about? Any consequences to that here?
I think they're down already, so I wouldn't worry about it. I think they're being supplied by collaterals, but if they were, then yeah, that's certainly something that sways me away from that. Drew, did you guys, I may have missed it, you've IBISed already? What's the size look like on this vessel?
well, that's.
What's it, seven?
Okay, while we're waiting, let me ask Eric. Eric knows a lot about this space. What do we know about IBIS use in iliac artery interventions? Is it helpful, doesn't help, doesn't matter?
This is the time to use it,
Yeah, so
right?
it's around
there's a
6 to
couple
7.
here,
Really-
a couple aspects here that are necessary. So if you didn't know, if you didn't use the Pioneer for crossing,
Make sure there's no RP bleeding going on here.
the IBIS is going to tell you where you're subminimal, where you're not subminimal, where you re-entered it. Surprisingly, when you IBIS more and more, you realize you go subminimal and you don't realize it sometimes.
I think the
And then
key thing here is really
sizing here is
prepping
really
your vessel.
necessity.
Because
We know
at
from
least in my
CT that you
experience,
pretty much need about
really,
1 millimeter compared to IBIS. So I always like to confirm it with IBIS versus relying on a CT scan. I do very little CT.
I have to ask the question that in this small woman who's under 100 pounds, heavily calcified diffuse disease, we better off undersizing. I'm kind of scared I'll go too big on with using the IVIS. But
Yeah, less might be more
If you're
here.
using covered stents, you're not going to get in too much trouble, but.
yeah, I'm definitely all about, in this case, undersized. I normally don't do that, but I think in this case, less is more. We really want to be, we want to try to do the best we can, not hurt her. in the best possible fashion. I think we're going to try to readdress that area right there. We got 90 pulses back. I don't know if you guys use focal IVL and just use the first 2 around lesions, or if you just deploy all of them in one area.
Yeah, you can see that resistance.
Yeah. It's good.
Is the wire in there?
Yeah, a little PVC.
Yeah.
Yep. Let's pull back the 014 wire. Yep, there we go. So being constantly mindful about where your wire is critical. Make sure it's not up. And that was the other thing with the reentry is when you reenter, making sure the wire goes up over the air arch, because you could technically reenter into the SVC, and it might look a little different then.
Okay, and so just we're all on the same page, Drew or Prashant. The plan after this is kissing stents. What type? What size?
What do you think? How many are voting on the panel for covered stents?
It sounded like it was nearly unanimous here.
Yeah.
Yeah. So I think that's the way to go.
Yeah, that's what we were thinking too. And you know, just before we went live, we had upsized to 7 French sheaths on both sides for that reason.
Go up there and use the rest of it. So we're gonna do I think on covered stents, especially with these, with this type of iliac system, we really want to be careful to make certain that your stent doesn't get, stripped off your balloon as you're re-entering. So I do like the technique of keeping your sheets up high and then pulling back your sheets so that you can really get a good sense of where things are. I don't know if you guys do that on a regular basis. I know back in the day when we would hand mount, and that was a little bit before my time, but it would. I have done a hand mounted stent, or a few, and it's a little bit tricky. I don't know, Kenny. That was not to pick on you, but those are your days.
Kenny missed the question there.
Oh, about hand mounted. Like, do you use this technique where you basically put the sheath way up and then unsheath it?
Yes.
No
That's the
brainer.
safest way to get in there.
The newer stents embolize less. That's definitely true. But I think just for imaging purposes, it's nicer to have a longer sheath up. You can
It's
do a lot
good
more with
practice
it.
in general. I mean, that's a big thing I teach my fellows is always bring that sheath back over your balloon when you're done and keep it past your area of treatment. That's another Kennyism. Kenny, what covered stents are you using right now?
The VBX or the ICAST, they're both good, I think.
I think me and you are the only people using ICAST anymore.
I actually use ICAST.
Okay, we got 3. I still use them also, but
Yeah, I think, the advantage of using an ICAST here is that they are 6 French compatible. So you can get away with that. Most are. Back that
So
up.
you're going to advance the sheet?
It seemed to.
Is it going?
Okay.
We are seeing them, yeah. Thank you.
Using kind of the balloon as a dilator, but I think we're going to need to switch out anyways.
Yeah, come out with it.
Yep. I'll take a picture from the other side.
Yeah, give it a little
They might need kind of formal balloon assisted tracking to really get all the way up there.
Yep.
yeah.
I think this case brings up a really interesting discussion around when we bring people for complex iliac procedures, we need to consider what's going on in the aorta as well. Because aortic aneurysm that is coincident means we should really think about an EVAR, and certain surgeons will recommend intervening on that earlier. This does not look particularly aneurysmal, but I wonder about anyone's thoughts about that.
And this, if there was an aneurysm here, I'm having trouble with the landing zones for the limbs here in the iliacs. What do you guys think? With an isolated EVAR strategy. Also, access. I know you can get down to. There's one product I guess that gets as low as 12 French, but I mean I'm also having trouble with the access considerations.
Yeah, so it looks like you have some issues now, Drew. What are your thoughts?
Yeah, so you got that dissection on the side. That was from our kind of attempted reentry. I think it's going to seal up. It's not communicating from above, so I think it's going to be okay once we get some stents in. The biggest issues here, obviously, I think from a C-route side, and from everyone's talking about cover, you don't want to jail all those lumbars and everything. So I think it's going to be okay. I'm just switching out to an 035 wire, so we have a lot of support. I really like to have a lot of wire purchase, so there's no question about where you are. I think once we get some VBX stents in here, and I'm just choosing VBX, I think covered stents here for multiple reasons. A, it's already sealed. I think we have data from the COVEST trial, but I also just makes me feel better. As you're going up on the uncovered stents, especially in something like this, it makes me extremely nervous that something's going to give, especially on someone so small. So we're hoping that we can get these covered stents up and show you guys at least that picture in the time that we have remaining. And then we'll have to obviously do a whole bunch of work down below with external time. And I think it was Vikas who said that I'm probably going to use, it depends upon what it looks like now that it's been treated in terms of using self-expanding. I'm probably going to use some self-expanding stents down there. That area down on the left, as you should see, that stent's been a little bit underexpanded. Probably just, we may need to use some shockwave there or not. I don't know what you guys' thoughts on underexpanded stents in the iliac. Yeah, 2 BJ.
For the audience, it's a nice article about fracture rates for covered stents in SCAI from March. Sahil Parikh passed it on, so check that out. It's a good review of 2 different type of covered stents that we brought up today. I mean, I want to ask a question. Do you line this whole thing in covered stents, or do you go to self-expanding when you get, midway down?
No, I think probably just for the proximal common iliac,
Yeah.
that's where it's probably most important. The rest of the way, it's probably just standard bare metals, and then you're self-expanding in the external.
Yeah.
And then how about that? So I just want to make sure we're clear on what we're doing in that distal aorta. Are we extending the pipe all the way up? Are we placing a single covered there to seal that up? And then what do we think about those lumbar collaterals down? And are we just saying that it's fine to kind of cover the whole thing because we're going to be reconstructed with antegrade flow? It's actually a little bit of tricky decision making. I think of that distal aorta is what I perceived here, but maybe it's more clear to you guys.
Yeah, I would check a gradient just proximal to where the dissection ends to see if that infiltration of abdominal aorta is also significant because
do what Vikas was saying. Yeah, I think that's a great idea. I like checking the gradients as well. So we're going to advance this sheath up so we don't have any issues in tracking, but also so we can do a little gradient. I do like to see that. Obviously, it's markedly hypertensive right now. Right now, I'd rather have hypertension than hypo.
distally, and the proximal stuff will just heal itself because it's a retrograde dissection that was created by the.
Where are you talking about a gradient from where to where?
The distal.
He's thinking about the
Distal aorta?
Yeah.
But you're not going to have a gradient because you're going to have a water hammer effect. I mean, you have you've included your outflow, so you're not going to have a gradient that's accurate when you measure it here. I'm not sure the purpose of that. Maybe I'm missing something.
This might look a lot better after the common iliacs get
I think you got to reestablish your outflow.
Yeah.
And then check it.
and
That's
then
what
you
I
can
was
check a gradient to see whether you need to do anything proximally. But
take the second.
So that's interesting because it's,
Grace will take the
that would,
second
move
stent as
away
well.
from kind of a traditional
Leave that there.
CRAP where you try to reconstruct the common iliacs into the more, into the distal aortic stent. So we're kind of not going for that here, it sounds like. Is that fair to say?
Honestly, looking at it now, I mean, this older patient, I think that's reasonable. I think about also this approach and then the collaterals that are still coming off right in Farino there that you might need with 2 covered stents here. So I kind of moved my strategy away.
Extend the bite.
I think where we're at right now, that seems to make the most sense.
Extending the bite to me seems easier. So,
Yeah.
what are you saying?
I was going to say extending the bite up, just dropping 2 covered stents up higher.
What do you guys think about that?
Yeah, opposed to an isolated aortic stent. I think
that's
what
good, Drew.
the slight debate was here.
Good.
Yeah, I kind of like right where that is. I wanted to take that picture just before I start putting stent in there and block it up. I mean, I realized, this is not a 30-year-old woman or a 50-year-old woman. This is she's got advanced disease, and I got to be mindful of just why we're doing this. I don't want to make her worse.
You got a subclavian to fix also still, so.
Yeah, right. I'd rather just do it. I think the subclavian is going to have to wait, my friend. Definitely the mesenterics are going to be an issue. So I just want to make sure that we're cool in the same area here. So again, if you see where that is, and I like using non-DSA here so I can really see exactly where we're at. I mean, I kind of like that. We're below the IMA. We've got those lumbars. I like the distance into there, and I think we're equal. You guys happy with that? Because I am.
Yep.
Looks
So
good.
we can
I
look
think
at the last
that's
picture.
a way to do it. From my
just by
perspective,
that
I would
calcium
not be a
on the
hero
right.
on the pressure here. I think go up in that distal
Well,
aorta,
right
and then I
there,
would just
on the
concentrate
distal
on post-dilating a little bit more, in the common iliacs. But
So where are we with, okay.
We're
the
okay.
sheets are off.
Yeah. I'm gonna make sure that we're okay distally. I don't know if you guys have ever seen somebody do that, but I have. Ready?
Yeah,
Start
ready.
going up to 2.
Okay, we're going.
I'm sure I've
to
seen
2.
people deploy stents into sheets. It's generally not recommended.
Okay, we're
4.
at 4,
Going to 6. It's nominal on this, guys.
12 and 15.
Right.
What size are these?
These are 659 VBX. We're at 6.
7-0.
Oh, they're sorry, 7. Oh, pardon me, 7.
So where are you?
I'm at 6.
6 as well.
Let's go to 8.
7's probably the smallest I put in there, even in small women. I think the 6 would be undersized.
No, you can push it higher later, but I agree with starting with 7s or.
Yeah.
And normally, I think in a normal male, I'd be going 8 to 9, but let's
Yeah.
start off a little bit on the slow side. I'm letting Prashant catch up with us here,
There we go.
because mainly we hadn't prepped on that side too much. You're at 6.
6, yeah.
Let's go to 8. Nominal, you said, was
12 and
12.
15. Yeah.
12 and 15. All right, 8. And I like to go slow on this. I think, our tendency, especially in the corners, is to speed up going to 10. I really like to go real slow in this aortic stuff. I don't like anything blowing up. Yeah,
Okay. Should we come
definitely
down?
feeling that.
Should we come down?
Let's 10. Let's hold it. 3, 2, 1, down. We made it to 10.
Minute 20.
So in that respect, I'm definitely going to do this technique and using balloon-assisted tracking to get that up. So we have a picture from above. We also have a pressure from above. You want to back that out and leave it. And I always leave the balloon on the wire, so in case I need to go back up with a rupture. First thing I'm going to look at here is her pressure, and it's still doing quite well. Thank you, God. And we're going to go ahead and... So we just need to, that's just outflow issues from the sheets.
Yeah, and we still have the balloon on
We
the,
still have
on
the
the
balloons
other
on,
side.
so fortunately I don't see anything blowing up in the aorta. If you guys do,
Let's take this out too on the
I think we can
right,
start post-dilating this.
and then maybe that'll be a bit more useful picture once this is out.
Yep.
Or just pull negative on the sheath while you're injecting it.
I know when we're teaching the fellows, they always use the 7 French because of this exact reason. You want to be able to visualize and you want to be able to see exactly what's going on. You ready?
Mhm.
Picture.
Go ahead.
All right, yeah, that's just outflow issues.
Yeah, we need
Yeah,
to
I'm
still
okay with
tack up the
Yep.
outflow there, yeah.
But I think we're definitely doing better. Let's take 2 720 balloons, I think.
You also got, you see that left common iliac there, looks a little underexpanded, but now you got a covered stent there, so you have a little bit
Yep.
of room at least to
Exactly.
put some
Yeah, I
pressure
agree.
on it. Yeah.
I think there's a lot of calcium in there that we didn't, we could have used.
But now you feel a little more comfortable leaning on it now.
Exactly. Sure. Just making sure you're taking a balloon in the contralateral side so you don't compress that other stent.
Right.
Exactly. So, yeah, good point there, Eric. I think that's the key thing. We want to deploy. We don't want to, stent 2 720s or 2 740s. 2 of them, please. We definitely don't want to mess up the distal abdominal aorta anymore. So staying far shy of that edge, I think, is going to be critical. And then hopefully getting a little more expansion here, I think, is going to be good. And then of course our outflow is going to be a challenge because she's so tiny.
Yeah, you're going to end up great. Drew, but I love your teaching points. Again, balloon on the wire for that first shot. Make sure you don't need it rapidly. And again, 7 French sheet. Those are important tenets for iliac intervention like this.
Got it.
Yeah, I usually, even in the corners, I do the same thing. The idea here is that we make sure that that everything is intact before we even pull it out of the body. A little puff to make certain that we're looking good. 7.
She really has a blood pressure of 250.
740 is fine.
It's okay, Derek. So just just being common sense. You don't want to be able to put a wire back or have to put a balloon back up in a perforation situation, especially in this situation. This is the only, procedure that has a pretty high mortality rate. If you're not doing this correctly, if you rupture someone's iliac, it can be fatal. That's important about informed consent and going through that with the patient and the family before you do it.
So just tell us quickly what your next few steps are going to be here, Drew.
Sure.
Your
So we're going to do some
post-op.
post-dills, try to make everything look as pretty as we can. We're going to probably pre-dill more down at the, we have a
We've got to take the
740.
sheath down.
Yep, we have a 740 now on the left for a little bit more length on post-dill. We'll do some kissing here and try to further expand exactly what's going on. And then we're going to probably do some self-expanding stents below. I don't think we need to cover it all. I know you guys are discussing that. I think it's going to see kind of what it looks like too. And then the key thing is getting our closure out, right? And really having that. You ready?
Mm-hmm.
Let's go up to 4, please.
Where are you approximately?
I'm
Show
okay.
me.
Yep.
Okay, there you go.
I think that's going to be the challenge, making certain that you have good expansion. You're going to go up higher because
Yeah, it's.
I'm at 6.
Give me a second.
So I think here now,
having.
having covered stents, everybody can breathe a little bit. She's going to have a little discomfort. You want to go up to 8?
Mm-hmm. I'm at 8.
Okay. Yep. Okay, dear. Okay. I think you were seeing some better expansion there. I know I'm feeling a lot better that that's a covered stent right now, and I usually go to when the patient starts having a little bit of discomfort. You want to fluoro save that for us?
Yep.
So we don't need any more radiation.
Okay.
3, 2, 1, down. We can further expand down here if you want to.
Of course, if she has more discomfort when you deflate, then you're in trouble.
Yes.
That's a
correct.
great point. Great point. Great
yes.
point.
Unfortunately, can you see our hemos too, guys?
Yeah, we're
Yeah,
at
yeah.
250 blood
so
pressure right now.
that's a useful marker too. So let's go up
go up
here
there.
too.
Yep, let's go up to 8. So, I mean, prep, really, I think the key thing for this case is really about getting the patient prepared, critical on informed consent, really making sure you have a strategy plan, having plan B, because of course plan A didn't work. I'm at 12 if you want to go up to 12. And then being able to really kind of get good access below. 3, 2, 1, down.
10 on the left, 12 on the right.
We can take a picture here and see what we got, huh?
Let's take the balloons back.
Yep,
first,
let me just do a little balloon assisted tracking. And that allows us to get up there.
Okay.
Leave the
I'm gonna
balloon on
take
the sheath for me because I'm paranoid. Just mean they're not
the
out to get
wire,
me.
And then let's take this back too a little bit, maybe.
We thank everybody for the opportunity to do this case. I think it's great for SCAI. And an amazing panel that you guys have up there.
Yeah, we didn't ask you, how long did it take to cross that on the right?
Yeah, you know, I started at about 8 this morning. You ready for sitting? Ready?
Yeah, go ahead.
Sitting. Yeah, so now we just have outflow on the right. That's fine.
Yeah, so I think that looks much better. I mean, right, we feel happier about. Left, I think we still have some more work to do.
Let me ask a question. You have some flow around your dissection antegrade. Does that bother you at all? Will you make the proximal struts any bigger, or you'll just leave it be and allow it to heal?
My feeling on that is probably maybe just try an 8 balloon up there and just tack it a little bit more, 2 8s. There's definitely some flow around it. It definitely, I think, will heal with a little bit of time. Some of that was the subintimal technique getting around, so there's definitely a lot of swirling around there.
I doubt the 8's are going to seal
Yeah,
it either.
I would say
Yeah.
that I think, obviously, a judgment call would use the 8, but I think the reentry is just a little higher, so I'm pessimistic on the fact that it's going to change much with the 8s.
Yeah, Jay, I think you're right. I think the re-entry was a little bit higher. So, you know, it's going to be, we'll have to think about exactly what we do at that spot, but you're probably right. But then, you know, we'll be putting in a, you know, self-expanding further down there.
Yep.
As our
All right,
next
so we have
strategy,
about
probably.
4 minutes left just to kind of wrap things up with you all. Talk about your post-procedure management of her. What does the antithrombotic therapy look like? You do surveillance on her? Depends on how she does clinically. What's your strategy?
So I think for her, I'm going to see her obviously in clinic. She had no pulses before, so following that pulse is going to be critical. Getting her kind of tuned up. She's going to be on dual antiplatelet therapy. She does not have AFib or anything to warrant doing anticoagulation like a DOAC. That would be another valid thing. She's really small and tiny. I just get a little nervous in these patients using even a little bit of Xarelto there because it does make me a little bit nervous. So I think just follow her clinically. At 6 months, I'll do the ABIs before she leaves. And then I repeat the ABIs with exercise. And key thing with exercise on the iliacs, because you may not pick it up just on straight up ABIs. So ABIs with exercise before she leaves. Again at usually at 3 months and then again at 6 months. And
Gotcha.
then 12
Dr.
months.
Alt, surveillance post peripheral intervention with imaging, or is it just all clinical assessment?
Well, often the patients are going to know first, so if they're the kind of patients that are going to keep in with you, I think you can go with that. Otherwise, you can get imaging-guided routine Dopplers.
What about the rest of the panelists?
One sec, wait, let me flush.
I would do just, so I would just do clinical follow-up, and if they don't have symptoms, I don't bother checking.
The only thing to think about in this case is somebody's severely hypertensive. It's probably going to be a nicely, it's a limited dissection in that distal aorta, but it's certainly sealed off distally, but kind of keeping an eye on that expansion at least at one time point may be indicated.
Yeah,
you guys
you
buy
guys
that
can
or
see
not.
that dissection right there. Definitely going to need to treat that and just use like a 980 self-expanding.
How many, is anybody on the panel that would use a
980.
balloon expandable stent in the external here as opposed to self-expanding?
I would just be self-expanding.
I'm not going to get, I don't know, either one would work. I'm probably do self-expanding, but
How far down are you going to have to go is the big issue here.
Yeah,
It looks like you're going to have to cross the lumen based on how that initial pictures that were shown about how complicated the access was. It's crazy. You have to use a dilator over a micropuncture wire just to get started.
Yeah, I think the entire external has to be treated on that side.
Yeah, you're right, Bo. The entire external definitely needs to be treated, and just to kind of show everybody where we're at there.
I think based on our initial pictures, guys, it was going to be difficult not to. I mean, you can see how far down practically into the CFA.
I think we got a spot right there by that lateral circumflex iliac to land that stent.
Yeah.
That's going to be at least where I'm
The
going.
reason I ask is because I've always used, by and large, balloon expandable stents, except for the centimeter or two above the common femoral head, the head of the femur. And
What do you do there?
I've actually really been pleased with the balloon expandable versions.
yeah, I'll tell you, I mean, when you stent that close to the external iliac to common femoral junction, though, there's a lot of compression that happens there. I don't know if you guys have run into this where you can get some distal stent compression. And that always worries me when you get that far down. And
No, I like I said, a couple of centimeters above the top of the femoral head.
yeah,
So you stay away from that. I mean, we do have the ICE trial showing some, benefit of self-expanding stents in there head-to-head. I don't like it. I don't like self-expanding up in the common iliac, but definitely down here, I agree with you, Eric. There's a lot of compression, a lot of movement, and definitely on CT, it's three-dimensional. It's coming straight up at you.
yeah.
All right. Well, we're running out of time now, guys. One last thank you to Drs. Klein and Kaul for
Great work. Old case.
Yeah, very difficult case.
Congrats, Drew.
Thanks, guys. Appreciate you.
Good luck the rest of the way. Thanks so much.
Be back at the conference. We'll try to get you some pictures. Thanks, guys. Thank you.